Hi, I'm Judy Persicilli. I have the privilege of serving as the CEO and President of Catholic Health East. We're living through a time of enormous change in the healthcare industry. Dramatic breakthroughs in technology and advances in medical practice have changed the way we minister to our patients and residents. The entire nation is rethinking the way healthcare is delivered and re-examining how we can provide the best possible care in the most efficient and effective manner. Several years ago, our sponsors, board members, and associates came together to strategically imagine what the ideal healthcare system of the future should look like. We imagined a system of equal access to all, one where quality and value are the standards, and efficient and effective care are fundamental aspects. We imagined a delivery system rooted in our mission to be a healing and transforming presence in the communities we serve, placing the persons we serve in the center of all we do, providing them with the information they need to make informed choices about their care across the continuum throughout their lives. Our Vision 2017 of person-centered care. Today we invite you to imagine along with us as you learn more about our care management pilots. These pilots were started in response to our Vision 2017. The Mercy Health System of Southeastern Pennsylvania, along with the Keystone Mercy Health Plan of Philadelphia, the St. Peter's Choices Program in Albany, New York, and the Sisters of Providence Health System's collaboration with the Hampden County Physicians Associates in Springfield, Massachusetts, have all produced extraordinary results and many lessons learned in response to our call to be person-centered. All focus on testing innovative models of care delivery that improve access, quality, and value while reducing costs. Let's take a closer look at how these initiatives are transforming the way care is delivered and the difference they are making in the lives of the people we serve.
With healthcare, we have a lot of different health systems that have different ways of storing information that don't talk to each other. Even within a health system or a health plan, you usually have multiple systems that don't communicate. And the challenge in healthcare right now is to bridge those systems to be able to provide that fluid transmission of information to the parties who need it.
Insurance companies, by the way, have all of your health information. So the majority of time and energy and effort and expense that we go through in developing a care coordination pilot is access to information.
When I first started, I had access to Keystone Mercy information. The doctors had access to their medical information, and there really was very little sharing of information. So part of the goal was for us to be able to share that information. So I was able to provide to the physicians current pharmacy data.
She can tell us readily what medications they've been on, have they been getting them at the pharmacy. She can also tell us if they had an ER visit at another hospital, which sometimes the patients wouldn't even know that or couldn't tell us the name of the hospital. I think a big thing is what medications we can actually order for the patients, because she's able to tell us what the insurance carrier would be able to pay for the patients.
You get your answer right then and there. And if it's not going to be possible, she tells you.
That care coordinator role helps bring together the communication to other medical entities, making sure that specialist reports get into the record, following up after an ER visit that the member had, things that are not part of the physician role but need to be controlled and addressed to be able to provide comprehensive care.
So once we have that healthcare information, we can focus on the other things that are important. The transitions of care, how we retrain our teams, what resources we need, and how we can begin to look at the timeline and the investment we have to make to get there.
We want them to see that this is their medical home. This is where all of their care is coordinated, and this is the place where their questions can get answered and their care can be managed without them falling into sort of those gaps that happen between home and emergency department.
There is a definite change with the patients' behaviors, especially the patients that Lynn has been able to connect with. I feel they are more interested in their care and they're more willing to come to the doctor's office.
I think that since I've come to Mercy, I've been able to understand how very, very important it is to take care of my health, not when something happens, but before it happens.
Now we can look at our whole population of patients, identify where the needs are, where the gaps are, and proactively go and try to close those gaps.
So what we really need to do is to be able to finance the role of a care coordinator in a primary care office, and that's going to require a fundamental change in how we pay for primary care.
And I think in this model that our team has enabled the patients to accomplish that they've been able to be supported, whether it's navigating the system that's difficult to navigate or being motivated or coached or encouraged to take on some of that accountability and responsibility for self-management.
The no-show rate here at the clinic has declined. Recent outcomes showed some decrease in ER utilization, in inpatient admissions.
The one thing most clinicians don't have is time. So anything that could save time and yet not interfere with quality is very valuable. This saves an enormous amount of time.
Philosophically, we're beginning to reset our imagination of what care might look like, and we're beginning to learn some of the techniques and strategies to do that.